I'm Adrian McConnell. I'm the CEO of the CO Research Trust, and I'm particularly excited for this lecture today, the topic of which is carbon monoxide and pregnancy. Um, I think this is probably one of the more long anticipated lectures that we've held over the last few years. We, the CO Research Trust, have worked alongside the gas distribution networks and iPiP. We identified risks in the maternity service and in pregnancy. I'm trying to think back. I think it was 2017 that we first started working with iPiP on this. I think there was a anecdotal evidence that there was an issue with the ability for midwives and other healthcare professionals to identify CO when they were dealing with pregnant women. And obviously, this is really important because the most important thing is to give babies a good start in life, and obviously the consequences of something happening in utero or at a young age has long-term, lifelong outcomes and consequences. So um, today, Hilary Wareing and Rachel Harrison from iPiP are going to join um, us and give you a good overview of the work that's taken place to identify those issues, but most importantly, identify the solutions. I think we're at a really, really exciting point now where we have the solutions to make women safer, and to make those that go into the homes to protect those women safer, to protect the protectors. Um, Hilary is the managing director of iPiP. Her background is in health research management and clinical practice as a nurse, a midwife, and a health visitor. And Rachel is, sorry, a public health midwife, and her work in smoking cessation brought her into the world of CO exposure, and we're very glad to have her. And she's been supporting a number of the projects that we and the GDNs have supported. Um, as is sort of, traditional, a little bit of housekeeping before I hand over to Hilary and Rachel. Any questions you have, if you could put them in the chat and we'll answer them at the end. And we will be circulating the slides and a recording of this video at the over the coming days after the end of this presentation. So that's enough from me. I'm quite conscious that there's a lot to get through. And in the name of time, I'm going to hand over to Hilary and Rachel now. Thank you.
Thank you, Adrian. And I'm hoping that Adrian, you will tell me now that you can see my slides.
I can, yeah.
Great.
Thank you.
That's my technical challenge done, hopefully, for the session. Hi, I'm Hilary Wareing, as I was introduced by Adrian, and I'm going to start the talk off, and then Rachel's going to come in, and then I'm going to come back towards the end. And as Adrian said, there will take questions at the end. So, what are we going to talk about today? We're going to talk about how we take the evidence and use it to reduce harm and reduce risk of harm to some of our most vulnerable communities. And within that, we would count pregnant women and their babies. And some of those women themselves are more vulnerable than others. Um, and we know that CO poisoning is a hidden and preventable risk, and it disproportionately impacts those most vulnerable. We've got evidence and we've got resources, and we're going to talk about those. But what we know at the moment is practice on a day-to-day basis is inconsistent. We're also going to talk about taking what we've already got out there in the sense of good and consistent practice and how we can utilize that to actually support better protecting pregnant women and their babies. So those of you who are working in maternity will know that currently we CO test every single pregnant woman at the beginning of pregnancy and at 36 weeks as an absolute minimum. Now, I know we do that because it's helping us help women to identify themselves as smokers. and get the support that they need to improve the outcomes from their pregnancy and have a smoke-free pregnancy. But this gives us a massive opportunity to also identify women who are at risk of environmental CO, not just carbon monoxide from smoking. Let's go on to next slide. So today we're going to talk about what the evidence is for practice, why we're doing this, what's in place, what's next, and how we're going to know we're successful. What's our measures of success? What do we know? One of the first things we did when working with court was asked to be able to do a literature review and just affirm what we know and don't know about the harm. And what we know is that environmental CO causes cardiac problems, causes growth restriction, causes neurological issues. It can form limb malformations and it increases the risk of miscarriage, stillbirth, and sudden infant death. For those of you who work around smoking, you'll recognize those. They're the same things that smoking causes. And we've got an opportunity here to actually reach out to yet another group of pregnant women and help them to have better outcomes in pregnancy. And we should remember, I know Rachel, I'll come back to this later as well, is where if you're a smoker, you can also be impacted by environmental CO. And I think at the moment, quite often those two things are split, whereas it's not either or, it can be both. All of it's preventable. But there's not one of us on the call today, not one of us out there that can sort the problem on our own. And like many other things, including, tobacco, it needs a system-wide act. It needs system-wide action. None of us can do it alone, but together we can make a real difference. And what's the difference we can make? Well, when we went out and actually monitored pregnant women's homes, what we saw was 6% of those homes had a high enough level to cause harm to unborn babies. And if we think of, you know, almost 600,000 babies born a year, that's significant numbers. 44% of homes lacked a working CO alarm. Now, the homes we were going into were mainly social housing and private landlord. All of those homes should have a working CO alarm. It's the law. Just because it's the law doesn't mean that it's being abided by everywhere. And I think 44% of homes not having that legal requirement really concerning. We also talked to women about what they needed. And they said they need more information, they need more awareness, they need to know what the signs are and what steps to take. And that sounds really good. However, we also talked to pregnant women about what else worried them in pregnancy. And there are many things that are of concern to the group of women we were talking to. And we have to be realistic about where this comes in their scale of concern. Um, and it comes fairly low against other things that are perhaps more immediate and more evident. So it means that as professionals, we need to step in and we need to support those women to have less risk in their pregnancies. We need to take some actions to help them. So, what do we think good looks like? Well, consistent approach. We don't want inequalities. We don't want harm from environmental CO to be driven by where you live and who your midwife is or what your fire and rescue service offers, etc. We want everybody to be able to get the support they need. To do that, we need confident and competent staff and we need guidance to help. So Rachel will come on in a minute and talk about the new UK Health Security Agency algorithm and guidance for this area. To get those confident staff, we need them to have the knowledge and understanding and to know what good looks like for them as professionals. So we'll talk about the e-learning that's been developed. We need escalation procedures for when CO is raised and many of those are now in place. Not saying we couldn't do more, but there is enough to really make a difference. And we also need to look at prevention. So Rachel's going to talk about the home fire safety visits and the CO alarm provision and how that can be accessed by pregnant women. So while we've raised an issue, and we know we need a system-wide approach. We have, I think, come a long way along the journey to being able to say to you, we've got something that we can offer out now that can be used across the systems across England and the UK. So I'm going to now hand over to Rachel, who's going to talk a bit more in a bit more detail.
Thank you. Thanks, everyone. So, along with Hilary and the team, this project has been my baby over the last 18 months, and I'm really excited to share it with you all. So, FECO, what does it stand for? Preventing harm from environmental carbon monoxide. It's always useful to have another acronym in maternity because we've got enough of those. Next slide, please, Hilary. So, just to give you an overview of what we've developed, and then I'll go into each in a little more detail. We've got the new UKHSA antenatal carbon monoxide algorithm, an e-learning training package, our new FECO pathway, and resources which we can share with women. And finally, this is all wrapped up in an easy-to-use toolkit which will combine all of these elements. Next, please. So, firstly, the new UKHSA algorithm. We've worked really closely with the UKHSA team to develop and pilot this algorithm. It's a new pathway to identify whether women are at risk from environmental carbon monoxide exposure from the results of their breath test, even whether they're a smoker or not. It's available as both a short and long version designed to fit in with existing practice in all maternity units. It's evidence-based, based on air quality and NICE guidance, and it gives us a really simple flowchart to use if a woman has a carbon monoxide reading of 4 parts per million or above, and it gives the maternity staff questions to ask and actions to take. So you can use the QR code here now to access both the short and long version and have a good look around yourself and read both versions. It was piloted across 6 maternity units last year to ensure we had really good usability from our midwives working on the ground and if any refinements were needed. Next slide, please. We've also worked with the NHS England e-learning for health team to develop a suite of modules on carbon monoxide exposure, one of these being specifically for maternity. Users are directed first to the generic module, which gives a good general overview of what carbon monoxide is, the sources, the signs and symptoms, and even a walk around a home with a gas safety engineer to spot signs of CO. And if any of you have an e-learning for health account, it might help if you want to go and find this, because it gives us all sort of personal take-home message as carbon monoxide can affect us all and helps us keep us all and our loved ones safe. So going back to the pregnancy-specific module, this discusses why carbon monoxide, even at chronic low levels, can be so dangerous to the fetus. The issues of half-life with carbon monoxide, so thinking about the time that we test women for their breath test. Film scenarios of suggestions of what information to give to women and what actions to take if maternity staff are concerned. So this was designed in conjunction with e-learning for health to give us bite-sized knowledge pieces with interactive learning. And it only takes about 20 minutes to complete. It's a free, easy-to-use resource for maternity staff to both further their knowledge and also contribute to their CPD. Next, please. And then one of the other things we found doing the research and having discussions with maternity staff would that it'd be really helpful to have something to actually put into the women's hands to help explain what carbon monoxide is. So from this, we co-designed a leaflet that can be shared with women during a supportive conversation to advise them of the signs and symptoms and actions to take around carbon monoxide exposure. We trialled this at a local unit with a range of pregnant women to check both readability and understanding. And it's also been used as a great pull-up banner, which is a great resource for scan waiting rooms where women will often spend a fair amount of time sitting and waiting and looking around and reading what's on the walls. Next, please. So moving on to the FECO pathway. At the same time as all of this has been going on, the maternity units of UHCW, George Eliot and South Warwickshire, both with the Warwickshire and West Midlands Fire Service, had implemented a pathway between them to offer a free home fire safety check for pregnant women with a carbon monoxide of 4 parts per million or above, again, both for smokers and non-smokers. So what we've done now is evaluated this pathway and all of the resources that I've just mentioned previously, and they've all been integrated to fit into this one pathway. So I'll first explain the maternity part and then go on to the fire service part. Next slide, please. So the maternity part of the pathway. As you can see here, it's a really simple flow chart. Again, when any lady blows a carbon monoxide of 4 parts per million or above, they can be offered a free home fire safety visit. And please note, this is not an emergency response. If there are any concerns with a woman who is symptomatic of CO exposure, then the woman should be directed to A&E and the National Gas Emergency Service called. This is a fantastic service, and if they're called, they'll get an engineer out to the property, usually within the hour. The pathway is there so that women can be referred or directed to the local fire service, but when this pathway is embedded within the maternity system with a direct referral route and data sharing agreements, then the outcomes can be transformational. Next, please. So moving on to the fire and rescue service part of the pathway. Next, please. Once the woman has been referred to the fire service prevention team, and just to note, women can be referred without having all the data sharing agreements. However, this does help the flow of information to and from the trust. The fire service team will take the referral and usually contact the woman within 48 hours and usually make an appointment to see them within 5 working days. These timeframes can depend on service capacity, and hence why this isn't an emergency response. When the fire and rescue prevention team do the home fire safety visit, which encompasses a variety of safety aspects around the home, so it can include fire prevention, escape routes, vehicle safety. There'll also be a discussion around carbon monoxide, the sources of this, and if the household do not have a working carbon monoxide alarm and they are eligible, then the fire and rescue service may supply one or signpost where they can get one. Some fire and rescue services are also able to check the ambient carbon monoxide in a property, giving an extra level of reassurance and protection to the household. Next slide, please. So when we put it all together, we have a very comprehensive pathway. This pathway has been reviewed with the data analysed from the 3 trusts I just mentioned and the West Midlands and Warwickshire Fire Service over the last year. And in that year, there were 157 home visits that were undertaken for pregnant women. In those, carbon monoxide alarms were fitted in 48% of the Warwickshire visits and 100% of the West Midland Fire Service visits. Also, 9% of these households were referred to that national gas emergency line, and the gas supply was disconnected due to the identified risk in 4.4% of these homes. And we know of one specific case at UHCW where the national gas emergency line was called to one pregnant woman because she was symptomatic, and it turned out she was sleeping next to a leaking gas fire, which was then condemned. Had that tobacco dependence advisor not picked up on this with the knowledge she had had, this could have been a very different outcome. We're really proud to have been working with the fire service, and as Hilary mentioned before, they've been doing some of our data collection, and combined with these visits, we really feel they're part of our healthcare community now and helping to protect our most vulnerable with their home safety visits. And it's not only us that thinks that, as we're proud to say this pathway has been nominated and shortlisted for a few awards, just winning one last week. Next slide, please. And finally, we're just in the process of refining the toolkit, which has everything in place for the service or the public health lead, which you'll need to implement this in your service. So it has template data sharing agreements, it has slide sets, it has the briefs for staff and all the resources that I've just mentioned, designed to be one complete, easy to use resource that can help you to implement in your service. And we will be rolling it out this year. And I'll now hand you back to Hilary to tell you how we're going to do that.
Thanks, Rachel. That was really, really, really excellent. It makes me reflect on just how much work has gone on over the last few years, and not just by us, but by our whole range of organisations. And I think up to date, we've had some real system-wide action, but we've been sitting in the background doing that. And we now need to ensure that what we have got in that toolkit actually can make a difference in practice. And we are very near now being able to publicly start to launch this, and to reach out to all the key organisations, to NHS England, DH, UKHSA, our local maternity and integrated care systems, our national and local fire and rescue systems, to say to them, we're not coming with a problem, we're coming with a solution to a problem. Can you help us actually implement this? So we will be looking at those national organisations to support the launch and rollout. Also, we're looking to the baby charities as well. And in fact, we were really lucky during our research phase, in this programme of work. Claire Harmer, the chief exec of the baby charity SANS, actually chaired our research committee. And so that's been really helpful and she also chairs the stakeholder group for maternity transformation. So she's been a really powerful voice for us in stating the importance of this issue. We're talking to the Royal Colleges, like the Royal College of Midwifery. Um, we're talking in local areas about how we get that professional engagement. But also we know that all of us, we do read our we do read our professional press, all of us, don't we? But on a daily basis, we most likely see more from our social media, maybe what's on the television, what's on YouTube, other 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 means of getting our information. So we are going to actually reach out publicly to talk about this risk for pregnant women, but also to reach out to professionals. So women know what they can expect and why we're doing this, and the professionals can identify the resources that will be useful to them. If we're asking for all this effort from the system, we know we have to link it to the national priorities. And this clearly links to Saving Babies' Lives Care Bundle and also the prevention health inequalities targets that we have. So our first measures of success, what are they going to be? Well, they're going to be adoption of the pathways. We are going to be able to support a number of early adopters. So please, those of you who are thinking, I really want to do this, watch out for what's coming. Watch out for when we reach out and say, we can start. Who wants to work with us? Who wants to be the trailblazers in this area of putting this in place and seeing what happens? But you don't even have to wait for that. That UK HSA algorithm and guidance is up officially on that website now. We actually launched it at the UK HSA's national conference some months ago. So you can go there, you can look at it, and you can be confident that that algorithm is evidence-based and it's tested. So please, if anybody from maternity, if you're working with pregnant women, especially if you're doing those CO tests, I would urge you to get onto that site now and start to look at it. And if it makes you think, still not sure how to do those conversations, engagement with those training modules that we talked about is key, and we'll be able to monitor the engagement with those. They've been signed off by stakeholders from all the key organisations. They've been tested in practice, and NHS England has signed them off as well. So you can go on there now and go through those modules. There's about 220 minutes, would you say, Rachel?
Yeah.
And you'll be through it. And I'm amazed how many people have been on that first module and realised that they may be a little at risk themselves, and gone out and bought themselves a new alarm, or just thought about getting their boiler serviced, or whoever does it, their cooker serviced. In the research, one of the things we found was that cookers were one of the key risks. People close the windows during the winter, so no airflow, and have old and inefficient gas hobs and no air, inefficient cooker, particularly while you're feeding your children, perhaps during the evening, trying to keep warm. Real danger period. We're not just talking about when your alarm goes off with all of this. Alarms rarely go off. It's good that it go off because it saves lives. But the level that causes harm to all of us, but most to that unborn baby, is so much lower than when that alarm goes off. And you might say, well, what are we doing about that? And we'll come back on that because things are starting to happen. There's conversations going on about that. Um, and obviously, when we reach out to identify those early adopters, what we intend to do, because that numbers is great, but we want some qualitative assessment of what as well of how we're doing. So we will be gathering insights and case studies, hopefully to promote the adoption in the wider system. There's certainly a social return on investment here, and we've worked with our funders to identify that. We know we can prevent and reduce harm, and it's not just the immediate harm. When we cause harm to an unborn baby, that harm may stay with them for the rest of their lives. So we know that if we're doing that, we're supporting not just a better start in life, but a better life and tackling inequalities. And it's not just about pregnancy. It is about pregnancy today, but we know the more we do in the wider system, then the more we will support better practice with pregnant women and will protect them. So we're also really, really pleased to know that we're about to start working on a programme for accident and emergency departments, for general practice, for ambulance crews, and for fire and rescue. And we've already got a package around vulnerable adults. So this is, when we say system wide, we're meaning really system wide. If somebody goes into A&E, then we will have the same knowledge and programs as if they've called an ambulance, if they've gone into their GP, if they've got a home safety visit from fire and rescue. We'll all be on message and all know what actions to take to prevent harm. So this is part of the journey. But I think starting with the better start in life is a really good place to begin. And I mentioned before that, Rachel and I may have been orchestrating this, but we've only been a small part of the team. And this is a selection, some key people that have played a part in what we have managed to achieve. But behind this sits our funders. And without our funders, none of this would have happened. So the gas distribution networks have been the most amazing support through the vulnerability funding. And without that, we would not be sitting here today alongside Adrian and his trustees at the CEO Research Trust, who've also funded us. And having that combined approach along with this team and a huge amount of goodwill from fire and rescue services and from the NHS, particularly the maternity services. Without that, we would not be here today and we would not be able to offer out the toolkit. Thanks for listening. Adrian, back to you.
Well, we got the last slide with Hilary with the resources on. Sorry, that
Oh,
was
beg your
the.
pardon. You
Sorry.
say I finished one early. Hey, let me just go back.
Sorry.
Share. No, good one.
So it's got the link to the e-learning resources
Have
as
we?
well as
No, it's not. Is it?
oh, I thought
No.
we had our last slide at the end. Okay. Oh,
Oh,
it's
there
there,
you go.
yes.
That's it. There you go. But you will be, as Adrian said, the slides will be available and also the full talk will be available for you who've been listening today, but also for others who couldn't make it.
Yeah. And
Thank you.
we can circulate the algorithm and anything else that it's okay to do. We can do that as part of the follow-up from this. Well, firstly, thank you to you both. It's funny because I've sitting and listening, and obviously I've been involved in carbon monoxide related policy for 16, 17 years now, and I was thinking back to when my second daughter was born, and we went to the booking appointment at the GP's, and they had a smoking cessation machine that they made her blow. And I got disproportionately excited and insisted on having a go as well, and yapped away at the fact that this is what I did for a living. And and that was around the time that I think, Hilary, you and I first met. And my daughter's now 11 in October, so it shows that this hasn't sort of come out of nowhere, and it's something that we've been working away at for a long, long time. So thank you to you both for sticking with it, and everybody who's been involved. I mean, the list of people who've been supporting this work, you know that is the tip of the iceberg. But there's some what I consider big names there. And when you put the slide up that had it was the 4 points around the value of the project. I almost found myself sort of cheering, because I mean that's what we're in it for, really, is to make those real impactful, positive changes. And from our perspective, in addition to the team at iPiP, yourselves, and Joe Pullen, and I think we need to sort of mention Adrian Hart, one of our trustees, former West Mids Fire and Rescue Service, who's been involved in this and has been a cheerleader for this for a long, long time. And Claire Harmer at Sands, who you mentioned. And you know and obviously Beth and Bryn at West Mids Fire and Rescue Service, who have been banging the drum and been supportive in this and a number of other projects. So yeah, no, I mean, it feels like quite a big deal to have got this far, and now there's an opportunity to implement this and actually make this business as usual for midwives and healthcare professionals. And your penultimate slide, where you showed the fire and rescue service, general practice, and other areas where this could potentially work, I've always felt that the maternity services is an area that, if we could get traction here and prove this can act as a model and an approach that can be applied in those other areas. Um, so yeah, I mean, yeah, uh, my Oscar acceptance speech over. No, but it's a big deal, because this has felt like a bit of a slog sometimes, and it took a while to get going, and here we are. So we've had some questions in the chat. So what I'll do is I'll take us through them, and then perhaps you can decide between you who's going to answer each one. So the first one is from Nicola Coote, and she asks, are you aware if the CO monitors that we use in practice, which are the Pico Plus, can be used to look at ambient CO levels?
Yeah, yeah. What I would say is, looking at ambient, it's not. It is a bit difficult. Because as soon as you go into a home, you've opened a door. And as soon as you've opened a door, you've let the CO out, and it takes time to build again. And therefore, you have to be very careful at not getting a reading that gives you a false kind of sense of security. One of the things, and so yeah, I just say with caution, one of the things we are looking to do going forward is to use wearable monitors and see what we find with healthcare professionals. We have been using those to some extent in one of our studies. Um, my view would be the breath test and signs and symptoms are most likely your two most powerful measures that you can use for this. And err on the side of caution. If you're concerned, escalate. You know, don't presume it's something else. I mean, one of the things we know in pregnancy is that the signs and symptoms of CO poisoning can look, a particularly low level chronic, can look very like the signs and symptoms of being pregnant, particularly in the early stages. But my view is take those two, be cautious, and I don't say ignore environmental, but just be careful of relying on that as a measure.
Great, thank you. Do you have anything to add, Rachel?
No, I mean
No?
purely though that those pico monitors are just a breath test. They won't
Yeah,
they
no,
won't do an ambient
but
reading in the room, I
No.
suppose. Yeah.
no, but there
Okay,
are some that do, but I would just say with caution.
great, thank you. Right, the next question is from Lauren Neal. I'm going to read this one out. There are a few acronyms in here, so perhaps
Okay.
you could clarify what they are. Um, any guidance on those with environmental CO, i.e., passive smoking or other causes, on their AN pathways, i.e., aspirin, serial scans, VTE scoring, consideration for IOL, as is done for smokers?
Yeah, so I can kind of obviously put some thoughts to this one. So we're still waiting obviously for this to kind of be accepted as part of Saving Babies' Lives guidance, but clinical guidelines still have to come from the trust. So what we've developed with the algorithm and the e-learning packages there is information as knowledge, but we can't obviously advise what the trust is going to do themselves. So that has to come specifically from the trust and their own clinical guidance. But hopefully all that we've done here will start shaping that.
Great, thank you. We've a couple of questions here from Eleanor. She's asking how can we access the CO leaflet for patients and pregnant women? Um, is there a link somewhere at the moment? Is it in the public domain, or is it something we can circulate with the recording and things?
We haven't put it in the kind of just in the domain at the minute because our concern is that it's not used in total isolation.
Okay,
And so our plan is at the moment is to put it out as a package so that we know that when that information goes in the trust, if the woman asks a question, we have an informed workforce. So it's meant to be um, an aid to a conversation
okay,
and to be able to take action rather than something that we use in isolation. But
great,
do
thank
get
you.
in touch.
Great,
And
thank
the
you.
same part there for the process of setting up the referral pathway to the fire service, that's all in the toolkit. So that's all included. So, we've gone through the process that we used and how we did it in the West Midlands. And so that all the learnings in there as well. So all the information will be there.
Great, thank you. I have another question from Lauren Neal. What can we advise will happen in A&E? Aware that COHB isn't done at every A&E and may be offered ABG instead.
Do you want to take this one, Hilary, or do you want me to?
Go on, no, go. You go first.
Well, like I
Okay.
said, we're waiting. We're kind of in conjunction with developing this new e-learning with A&E. Plus, we're hoping that the UKHSA guidance, the standard one's going to be updated as well. So again, like Hilary said, it will all fit into this whole package. But I suppose the thing is, if you're referring a woman in that you've got concerns with CO poisoning, then you need to make that very clear and say, I'm very concerned. I'm referring in for this. She needs to have a COHB.
Yeah.
And as far as we're aware, that just comes from, that's just how you have to refer her in with it.
Yeah. I would say that in putting the path, if you're going to put the pathway in, what a key thing is to think, where do we test? Some maternity units do test themselves, some
Mm.
referring to A&E. Um, but to have had those discussions with your A&E department and leads and have those pathways for your pregnant women before you get to a situation where you need to try and sort it out when you've got a woman who you're very concerned about in front of you. So I think that the toolkit actually prompts those conversations to make sure that you know how it works in your organization.
Yeah, 100%, because many maternity units have their own blood gas machines. And so actually they can do COHB on those, but obviously that's got to come with permission, obviously, from management and consultants and whoever else before you start running those through there.
Yeah. And it's interesting, I think, to note, and I can't, we have got a lecture on this, and it was also in one of the papers we just published, along with Sheffield Hallam, is that the baby CO, so when you've got a baby in utero, the CO climbs more slowly. It continues to climb after the woman's CO level has peaked, and it takes longer to go. It takes longer to come out of their system. And so, one of the key things to understand, not just in maternity, but for your colleagues, for instance, in an A&E to understand, is that while the pregnant woman may look like she's recovering, the baby's levels and harm may still be rising. It's a complex situation in pregnancy. And I think that's why, that conversation with the colleagues who may treat CO poisoning is really important to have before you get into that situation.
Great, thank you. Okay, so next question is from Eleanor again. Is there a level of CO ppm that equates to CO poisoning? What level reading should mean someone is referred to A&E even if they're not symptomatic?
That's in the algorithm.
Yeah,
Absolutely in the algorithm. And I would
yeah.
say that it errs on the side of caution.
Mm.
Um, there's lots of grey areas, I think, in CO, which is one of the problems because it's obviously you can only take, for instance, a breath test reading at that particular moment, and because half-life is 4 hours, it changes fairly quickly. Um, so it will be it is a clinical judgment around treatment.
Okay,
But WHO now says, the World Health Organization would say that nobody should be exposed above 4 parts per million for more over a 24-hour period. So it is quite low levels when we start to get harm. And at 10 parts per million, that, 4, it's about finding out where this is coming from. At 10, you need to take action because the likelihood is you're seeing women mainly outside the home. It could be hours since they were actually in the situation where they were being poisoned. So the likelihood is you're seeing readings that are much lower than they
Mm.
have been in the situation where they've actually been being harmed. Rachel, you got anything in
Yeah, and just
that?
just to add to that, the lady that we saw at UHCW, she was an ex-smoker and her carbon monoxide was 7 or 8, so it wasn't especially high, but she was symptomatic. So it's really key to obviously ask about the symptoms and and also other cohabitees as well in the home. So it might not just be the pregnant woman herself. And then the other, I suppose, part of answer to that question is, you know, then should the blood be taken for the COHB? Then there are obviously, again, dependent on the time when that blood's taken and the half-life, then they do say that anything with a COHB greater than 10% with symptoms then is indicative of CO poisoning.
And I would always say, I mean, as a midwife, I think most like Rachel, I would always say it, use the algorithm, use your knowledge,
Mm.
but actually just use that clinical judgment. You are standing in front of that woman. It's you that's there. It's you that having the conversation. Trust your judgment. And if you're concerned, make that referral. Don't doubt it. Make it. It's far better that they go to A&E and somebody says, no, honestly, it's fine, than you get the decision wrong in the other way and you send them back to a home that has got a problem. And one thing, I tell you one thing we didn't mention as well, and I know, Rachel, that we heard it quite a bit about clinical staff being quite concerned about making that call to getting the gas engineer out and what happens when they go and there is a problem and they cut the gas off and people get left in, what you might perceive as difficult conversation, different situations. The gas distribution networks have additional offers for vulnerable groups. And they all, if they know somebody is pregnant, will treat the pregnant women as vulnerable. And some of those women can also be on the priority services register, which allows them to be seen as a priority because of factors in their lives across all the utilities, not just gas. And in those situations, they will get an enhanced offer and be supported, not to be left in a situation where they can't keep warm or they can't cook. They will receive help. And we are starting the journey of looking at pregnant women being part of that, officially part of that wider priority services register as well. But the gas industry will certainly all treat them as a priority if they're pregnant.
Brill. Thank you, Hilary. I'm quite conscious of time, so I'm going to move fairly quickly through the questions. The next one is from Steve Hearn, our friend at British Gas. Is it true or false that pregnant women will naturally have a slightly higher COHB blood reading than non-pregnant women? I don't know whether you covered that in your earlier answer.
Very slightly. There is
Yeah,
obviously increased endogenous
yeah,
production when women are pregnant, but it still
yeah.
shouldn't hit over thresholds
Okay,
on a COHB test. And like I said, in conjunction with signs and symptoms as well. But
yeah,
yeah, very slightly increased endogenous production. Yeah.
And the,
great.
the
Thank you.
algorithm allows for the differences in pregnancy.
Great, thank you. We've had a couple of queries around summaries and minutes from the meeting. We'll be sharing a recording, and then there will be some materials that will be circulated, and obviously in due course there'll be the pack and things. And I think if you have any particular questions on reflecting on today, if you get in touch with us at court, we can put you in touch with the team and get those questions answered for you. Okay, with a comment from Bryn at Westmeads Fire and Rescue Service. With regard to the 100% CO alarms delivered by Westmeads Fire Rescue Service, we undertook the opportunity to provide all homeowners with eco alarms to support the downloaded data through prevention and response activities. The iPiP was placed on all frontline appliance mobiles. Has provided valuable data and support real-time information regarding levels of exposure to the occupant and help decide the correct pathway for intervention. So that's a really good example of technology being used in a really practical way to help us understand how best to treat people out in the field. Um,
I think
so,
that's quite an interesting one, Adrian. I'm trying not to mention certain, not trying to advertise, but some alarms you can actually put an app that's connected to them onto your phone as a health professional. And
mm,
literally, even I can manage this, and this is a miracle on my technology expertise. You can literally put your phone up to an alarm and it will show you what the levels have been over the last 4 weeks. It
yeah,
takes seconds, but it's one of those things that could save lives.
yeah,
I think also the other thing to add about CO alarms as well, and it's something, we've covered in the e-learning and the resource pack as well, is that CO alarms only alarm at that point the householders have got to evacuate the house. So as Hilary says, they're like a death alarm. They will not alarm at those low level leaks. So
yeah.
that's just a real consideration as well, that we just don't want women to feel falsely reassured that they're, just because they've got a CO alarm, that nothing else can happen in the
No,
home. So it's still having that awareness as well.
yeah, it's a sort of second line of defense, isn't it?
Yeah.
Okay, Ellen asks if the toolkit will also be shared with the health visitor workforce as they see people antenatally.
Yes.
Yeah,
Yeah, well,
bro,
it will be available to them. And we
bro,
have good links with the Institute of Health Visiting and do some joint work with them. So that's where we will be going to look at that.
great. Thank thank you. Daniela asks, is there any additional informational guidelines on things outside of environmental factors that might trigger increased CO levels, such as lactose intolerance?
Yeah. Yeah.
So that's mentioned in our e-learning for health modules regarding that, as well as other conditions of diabetes and sickle cell. However, it's just to say there isn't sort of the guidelines as per se in there, but just obviously to have that as a mindful, it could be a factor, but not to preclude environmental CO.
Okay, thank you. Wendy asks, what is the research behind the acceptable level of CO pregnancy being set at 3 ppm or below?
Oh, there's a lot of papers around that. It most likely would be used. We're literally about to we're pre-publication on a paper about the harm and the levels at the minute, Wendy, and that might be useful. And we'll make sure, perhaps, Adrian, that you can get that out once it's up pre-publication.
Yeah, yeah. What we can
Uh,
do is once it's in the
it's a
public
lot.
domain, we can
Yeah,
we could circulate it to attendees.
yeah.
Um, if anyone doesn't want that, if you let us know, we'll make sure it doesn't come to you. But I think it is going to be very, very interesting.
Yeah, I mean it is challenging because I know, particularly because I work in the world of smoke-free pregnancies very much as well. It is a challenge sometimes because it's that mix between tobacco and environmental factors. And I would say for any of you who are on the call who are working around smoking in pregnancy, particularly things like the incentive scheme where women who have quit smoking receive a love to shop voucher for keep keeping themselves smoke free as they go through their pregnancy as an incentive, and it works really well. But they can get knocked off course by having some environmental CO in there. So for those of you that perhaps are undertaking that program, having this knowledge and helping women think about how they can get rid of any other sources of CO that might be impacting them as much as they can will really help to ensure that any CO that you're recording is due to tobacco, not to the environmental issues.
Great, thank you. Okay. So Callum Brown, who's a research paramedic at the East of England Ambulance Service, Callum says, you had an arm of the algorithm where women might decline referrals. What were the reasons for those people, for that people, sorry, what were the reasons that people declined referrals? Was there any alternative follow-up for these people? Was there any consideration of other people in the house at risk or safeguarding children?
Yeah, good question, Callum. So often it would be, oh, we've had our boiler check. No, I don't want to visit. No, thank you very much. So I suppose it's very much in combination with the leaflet on CO silent killer, the fact that the workforce have done the training to explain why we should offer these home fire safety visits, just as that overall well-being check in the home, to then obviously really advise women why they should consider having these home fire safety checks. But
I
no,
could say they'll also be offered again. They'll be CO,
yeah,
if it's been raised, they'll be CO tested the next time they're seen by the midwife, and they'll
yeah,
be re-offered.
yeah. So the arrow then followed into documenting the notes and reoffer. It was part of that pathway.
Brilliant, thank you. Okay, we're coming towards the end now. Um, Mary O'Shaughnessy from Cadent just has made a comment that pregnancy is automatically included in the Priority Services Register eligibility for Cadent's network, and Cadent, the gas distribution network that cover kind of the main central swathe of England and Wales from North London and East Mids, sorry, East Anglia through East Mids up into the northwest. For those who don't know them. And finally, Honesty is asking, do you know what the level of CO that triggers a CO alarm is? Gonna put you on the spot?
That's that's where I'm gonna need Bryn to jump in if Bryn's on the call here because it's one of
Yeah,
those ones that I don't want to get it
yeah.
wrong.
Yeah,
It's the time weighted average, isn't it?
yeah,
It's
yeah. So it most of them start at 30, but it can be up
mm,
to 2 hours continuous
mm,
for that. And then as it climbs, kind of at 50, it's less time. I think at 100, it's like 2 minutes, isn't it?
Yeah,
At
yeah,
150, it's immediate. So it depends what level it is, but it has to be continuous for a certain period of time. And
yeah.
we know that under that, so over 10, we can track harm. So it's a lot lower.
Okay. So it's 30 parts per million.
That's it.
The
Yeah.
alarm won't activate for 2 hours.
Yeah.
50 parts per million. The alarm will activate between 60 and 90 minutes. 100 parts per million. The alarm must activate between 10 and 40 minutes. And then 300 parts per million. The alarm
I
must
always excellent.
activate within 3 minutes.
Yeah. Yeah.
So
It is,
in
it is. It's telling you to get out the property. It's not
yeah,
telling you you're being
no,
harmed.
no, no.
And that's
Okay,
and that's that before I worked on this, I'm not sure I'd have understood that.
no,
But that doesn't mean you don't need an alarm. You do. It'll save your life, but it
yeah,
won't necessarily harm you or your family being harmed.
no, no. Um, there's a final comment from Suzanne at Cadent. And I think she speaks for us all when she says, "So great to see all of this together after many years of research and hard work. Thanks to all of you who've put so much hard work into making this happen. It's really exciting." And I think that's a really, really nice place to close out this lecture. Yeah, I mean, I think, do you two have any final comments or thoughts before I do the Jerry Springer ending? Um,
I think all I'd ask was, can you make our job easier? Actually start to engage now, even before we start to reach out to you, because it's sitting there and it's ready to go. And please feel free to engage in all of it, and watch out for us coming out with the launch of the packs more formally. And just remember this, for me, this is, even though it's not in the Saving Babies' Lives care bundle, for me, this is a Saving Babies' Lives intervention.
Yeah.
Great.
And
Thank
I
you.
think only just to add on, as coming from a former public health midwife, this resource toolkit is designed so it is all there for we know that midwives have got busy lives, and just to try and bring in things. So, I've designed it there in mind that it is all there. The slide sets, the briefing, the data sharing agreement. So you're not having to reinvent it. So
Yeah,
hopefully all there as one.
yeah. And also to remember that it's not only midwifery reaching out to things like fire and rescue. If there's fire and rescue people on the call, please feel free to reach in to your local maternity unit.
Yeah. Um, well, I think all that's left to say is thank you to everybody who's been involved in getting us this far, and thank you to all of you for taking the time out to come and listen. Rachel, Hilary, I think you're underselling your role in this. I mean, this would not have happened without you guys continuing to swim against the tide. I've been involved in CO, as I said earlier on, for 15, 16 years, and it can feel like swimming through treacle sometimes, and progress is incredibly slow. But this really, really feels like something that is going to actually move, and it's actually going to have a real world impact. So I think we and the board and the team here at Core are really glad to have been, a relatively small part of this. And so, yeah, let's get on with it now and get it implemented. And, perhaps this time next year we can come back and, talk about what a great success it's been. Um,
100%.
and finally, thanks to the court team for organising this event and putting it on and making sure that it's all run, so smoothly. Next month, we've got our final lecture in the series. That's Dr. Derek Steele from Leeds University, and he's going to be talking about the work he's been doing on the electrophysiology of the heart and CO, and that's on the 21st of May. So I think that's gone live now, and you can sign up. It'll be on our website, and if you are on any of our mailing lists, you're sure to hear about it shortly. I hope you'll have a nice afternoon, and thanks again for attending. Goodbye.